So my talk is really about my transplant journey. And first of all, I want to thank you guys for inviting me to come here. But also, this is our 40th year anniversary for medical school. So I want to really express my appreciation for the diploma of medicine that I received here 40 years ago, this coming June. This really had led to an incredible professional life that I have treasured and enjoyed every single day ever since. Today I'm here to tell a different story. It's a story about my own transplant journey and how it was to go through that. But also, since this is a CME course, I've also and interstitial lung disease is a kind of an unknown or not very well known diagnosis, I should say. In fact, at home at Mayo, of course, I didn't really know much about it. I heard the term interstitial lung disease, and I, as I became more apparent that I had something, people would come up and say, "What's wrong with you?" And these are colleagues at Mayo, and I'd say, the diagnosis, and so, "Oh, it's that." And unless, of course, they were cardiologists or pulmonologists, and I suppose the pathologists would know about that too. But it's a rare disease that I had, and I'll go through that. And the other part I want to say here is that it's a story about, it's both, I divided up in three different levels here, and I'll come to that in a minute here. But this story or my journey through this taught me some very important lessons, not only for life lessons, but also as a provider as I was the patient. And that's what my talk is going to be. Let's see here if I'm here. It is really a story of immense gratitude. First and foremost to our Creator, who is the ultimate life giver. But it's also a story of gratitude to Mayo Clinic and the people that have worked with me and took care of me. Their genuine care and expertise. I really don't have words enough to express the gratitude I feel for them. I've divided my talk into three main sections. First of all, again, since interstitial lung disease is not a very common or, again, poorly known among most of us, I've given an overview of what that is and what the subtypes are, and then going into my more personal transplant journey as a patient and from the personal point of view. And I'll end with basically, why did I get this opportunity? Why did I get that chance to live longer? And there's no doubt about that. So disclosures, of course, I have to put that up. I have no financial disclosures but I am, if I seem a little biased to Mayo, it's because I'm brainwashed. I've been working there for 35 years. And so if it comes across as positive or very positive to that, that's really my world that I live in. So, and then I also wanted to mention, I'm not a pulmonologist. So if there are depth that I don't have or can give you, it's because I'm an ER doc. And we do everything whether we know it or not. That's kind of how we portray ourselves. So what is interstitial lung disease, or is also known as ILDs? Maybe I could get at least a hand here. How many in here would know what UIP is, what that stands for? I think there's some in here, but that I've told that may know a little bit about it. But it is, it's called usual interstitial pneumonitis. Well, that's equally kind of bizarre, but I'll get into that a little bit more later. Another subtype is IPF, or idiopathic pulmonary fibrosis. Then you have NSIP, stands for non-specific interstitial pneumonitis. CHP, which is chronic hypersensitivity pneumonitis. RA associated, rheumatoid arthritis associated interstitial lung disease, and systemic sclerosis associated fibrosis. I will focus primarily on the first three because those are the idiopathic forms. I mentioned a little bit about maybe one or two of these other ones, but that is more close to my journey. So that's what I'm going to focus on. UIP and IPF, what's the difference here? Will be next slide. And then non-specific, also going into that a little bit more. So what is the difference here between UIP and IPF? What is the difference? Really, it's very, very similar or even identical. The difference is that we call it IPF when it's a clinical diagnosis. UIP really requires a pathologic specimen and diagnosis of that. Sometimes a high risk, high sensitivity CT scan may strongly suggest UIP, but then again, to be truly call it UIP, you probably should have the biopsy. Oops, sorry. Sometimes the later stages of some of these other causes, even radiation-induced, rheumatoid, bleomycin-induced, and so on, in the late stage of the course of these diseases, they may often take on a pathologic changes that looks very, very similar, sometimes may be included in that. It's kind of a fuzzy borders here a lot of times, at least the way I understand it. How common are they? Not very common, 75 per 100,000 population. And I don't know if that's by our total population or is it really in the target group, which is 50 years old and older. And of those, about 50 of them includes the sarcoid rheumatoid RA or systemic sclerosis. So that's 50, so it remains 25 roughly are idiopathic. Now of these known sarcoid RA and so on, about 25% will have a gradual progressive form that could bring you into the UIP or IPF form. So IPF, you see all kinds of numbers all the way from 8 to 60, but in the upper Midwest, the male, and the most commonly quoted number is 1 case per 50,000 per year. So not very common, and that's why we, non-pulmonologists aren't all that terribly aware of it. What about prognosis? The NSIP and the CHP categories really have a pretty good long-term survival. Again, you're talking about these people typically are diagnosed in the 60s or maybe 70s. And so these numbers are really not too bad, 45 to 70 for NSIP, CHP 50 to 80%. And typically, it seems like the pulmonologist, if somebody asks, how long do I have to live this? Well, if you have one of these two, they say, well, you're probably going to most likely die of something else and not of your lung disease. But IPF and UIP, on the other hand, once you have that diagnosis, virtually 100% will be dead in 2 years. So and there's not a whole lot you can do about it. We'll go into that in a little bit. So why does this happen? What happens here? Obviously, fibrosis and scarring is a normal response in wound healing. Our lungs gets exposed to pathogens, viruses, inhaled this and that, dust and toxic and fumes and smokes and so on all the time. And the lungs get injured, but they heal. They get some fibrotic, and then eventually it resolves and it goes back to normal. And people die. Obviously, 90-year-old lung looks different than a 20-year-old lung, but overall, it's much more of a normal scarring process. The idiopathic forms, on the other hand, they have an exaggerated response to disease-specific triggers that causes cascade of fibrosis and extracellular matrix deposition. And we'll have a little bit more of that later on here. Signs and symptoms typically starts off with people say, I get really short of breath when I try to do something. And then as they get worse, they may start to have a cough, a progressive cough, and it's usually dry cough. And then at some point later on, they may need to have some oxygen. And how do providers follow it? Usually by this time, hopefully they're followed by a pulmonologist, typically signs and symptoms, chest x-rays, pulmonary function test. And here, the FEV1 and FEC seems to be very specific and sensitive and a very good tool to use for this. High resolution CT scans are often useful intermittently to see if there's possibly a change where you have to change gears. in the diagnosis. And we'll talk about that a little bit some more. Treatment, unfortunately, it's primarily symptom and relief directed. Commonly, you'll put them on steroid, prednisone, maybe 5-10 milligrams, typically maybe a little higher to begin with, come back down to 5, and then cough relief, and at some point, again, supplemental oxygen. In IPF, you may try some antifibrotic therapy, may or may not work. It's, you try it and see if it works. With the CHP or chronic hypersensitive pneumonitis, obviously you want to avoid what is it that in here that the patient may be exposed to. Like it could be as simple as down pillows or down comforters or things like that, or other things in the environment that they get exposed to. With those patients, you may try some immunosuppressive therapy, and in NSIP, same thing, immunosuppressive, or maybe even try antifibrotic therapy. So not very much to try, and a lot of it is not all that effective. So let's switch gear here a little bit. Let me have a sip of water here. I think I'm getting a... So that's kind of the backbone of IPF or ILDs. And just the kind of the basics, so I have a basic understanding of that. So let's put a little bit meat on this and take a case and follow that patient over time. So here's a 55-year-old male. He presented to his doctor with dyspnea on exertion. He started to notice that when he's trying to exert himself, he became very short of breath, thought, oh, he's just out of shape. So I tried to exercise, tried to start some running, and did this same running course for 2 weeks. And after 2 weeks, there was absolutely no improvement. So something had to be wrong here. Was otherwise very healthy, a little hyperlipidemia, no family history. And so when he was seen by his provider, the only thing that was noted on the exam was that he had some fine inspiratory crackles. Chest X-ray, I don't know how well you can see it here, but it was read out as normal. But you could, let's see how I'd use the marker. You can see here, it looks a little bit lighter, like a little cloudy almost. And so I suppose it was interpreted, maybe it was just a little bit of a low penetration or underexposure to the, and so it looks like that. But later on, when they looked at this X-ray again, they said, oh, there's some fine reticular infiltrate present on both sides. 6 months later, his symptoms had worsened a little bit, and now you can see a more definitive, a little bit coarsening of on both sides here. I don't know again how well you can see it there with the lights there, but anyway, perhaps you can see that. Again, he was a little bit more short of breath and had developed a chronic dry cough. Now, here I'm going to ask you to play a mind game a little bit. Anything. So you just look at this here. So a patient had 3 PFTs at this point. So ignore this. I'm not all that IT savvy, so you'll have to kind of blind yourself. Don't think about this part here. This is where the patient is, and this is really all we know at this point. So really, these pulmonary function tests are really very close to normal, a mild reduction in the function. And again, it's FEC and FEV1 that we're following. FEV1 in red here. Again, there was no known exposure. It was seen by a pulmonologist. Explored this very carefully. Sent off a genetic test even, and this was negative. And then continued to ask, well, okay, well, how about hypersensitivity? So something in your environment that you can think of, and he listed a whole bunch of things that potentially. Now, we did have down pillows and down comforters, so I said, well, let's get rid of that for a while. Didn't make any difference on this particular patient. So now we're into year 2, and you can see that this fine reticular infiltrate is clearly there. It's clearly worsened, and the diagnosis, radiology diagnosis, was progressive NSIP. or non-specific interstitial pneumonitis. CT scan was done in year 2. You can see here that there's some what seems to be a little bit abnormal here in the periphery. And this was read out as peripheral reticular fibrotic infiltrates with some associated traction bronchiectasis. Pulmonary function test at this point, at year 2, you can see here a little bit of a, it's come down from originally here. You can see here, you went down on one, came up a little bit, which is pretty common for NSIP or non-specific interstitial pneumonitis. Later in year 2, chest X-ray, a little bit more obvious here for these infiltrates. And the readout was actually some coarsening of these infiltrates as well. You should be able to see that by now. So let's go ahead here and the progression over the next 4 years. Let's just do that in one slide here. So there's a gradual worsening of the shortness of breath. He started to have a dry cough. It was on low dose prednisone, and the cough was so intense with paroxysm sometimes lasting 30, 40 minutes. And the only way that he could break those was if you gave nebulized lidocaine. I don't know if you ever had that before, but it's very, very effective if you nebulize it, but it has to be a high percentage. And sometimes it's not real easy to find, because I don't know why, but pharmacists have a hard time sometimes finding the 4 to 5%. But it's very effective, and typically when the patient uses it, it feels better for several hours after that. They had tried some immunosuppressive therapy, but with that, actually symptoms seemed to be worse, so they stopped that after a month only. At this point, they had done a sleep study which showed some dip into the mid-80s. And so he was started on supplemental oxygen at night. So let's go ahead again, move over the next couple of years here. We're now year 6. You can see a significant progression of the scarring on both sides of the lungs. And it was read out as progression of non-specific interstitial pneumonitis. CT scan said the same thing. It confirmed really what the chest X-ray said is really just more of the same thing, more scarring with a little bit of traction bronchiolitis. So this was done in order to assess what was this diagnosis really the correct one, and the answer was no. It is NSIP. So it was they stuck with that. So let's move ahead another 2 years here. Patient continued to be more and more symptomatic, same therapy. And at this point, especially after he had a flu-like illness at one point, and after that, he needed oxygen all the time. Started off with about 2 liters, 2 to 3 liters per minute. And again, you can see here, again, ignore this part. So this curve is now going pretty ominous straight line here. Now, of course, if you would draw that out, you would guess, okay, he would probably have died somewhere in here, unless this would change. At least that's the intuitive, interpretation that most people probably would have. So here we are at year 8. Again, we have moved ahead a little bit more here, and here is the definitive worsening with this coarse interstitial fibrosis. So a CT scan was done again at this point, and now you see something that is dramatically different here compared to before, especially on, of course, there are many, many cuts, but I pulled out one here that seemed to be representative. So on this side here, you had these blebs, pulmonary blebs, that is really consistent with highly suggestive of UIP, and certainly IPF. You could call it IPF at this point. So this was almost pathognomonic for UIP. Again, he was at this point oxygen, like I mentioned, and at this point, then the question came up with this diagnosis that now was different with a different prognosis, should we consider a lung transplant? So they decided, okay, let's get a transplant consultation with a transplant team. So what does it take to become a transplant candidate? Well, there's some very strict criteria in order to qualify for that. They will assess basically if the patient truly qualifies, and very rigorous criteria. And even though these criteria may change, may be a little different from center to center, age cutoff is important here because it's obviously a very big operation, very expensive. What's the life going to be after the transplant? Is it worth it, kind of thing? So some centers that have maybe not so many organs coming through, they often will put it at 65. Others may extend that to 70 or even 71, 72 if the patient is a young 70-year-old, so to speak. BMI comes in. It's also a very, very important factor because of the perioperative risk. Usually they say 30, 32, hardly ever you see higher than that. If you have a BMI higher than that, the even perioperative risk of survival is very low. And so that's an important factor. Then other factors, of course, if you have UIP, that's a high, patient is going to die, there's no doubt about it. So the diagnosis is an important factor. Other diseases the patient may or may not have, like cardiac disease, malignancies, diabetes, reflux disease, and the functional status, how active is he. And very interestingly here, well, they look very, very carefully at the social support. What support does patient have? And also the resiliency. This was kind of new to me when I first heard about it. But they look at what's the patient's faith, what's his outlook on life. And these are very, very strong factors for a positive outcome. If they have low resiliency, then typically they do worse. And of course, the social support is very important because most centers will say you have to have a caretaker post-operatively 24/7 pretty much for the first 3 months. So you need to have that. Some people actually hire help to do that, and they can get by with it this way. But resiliency is what it is, and they did look at that carefully. So for our patient, the good news was, yes, you're a candidate. So then the question was, when will the patient get one? Well, that's also a very complex decision to make. And it's all coordinated by an organization in the US called UNOS, which stands for United Network for Organ Sharing. This is a national organization that divides the country into basically 5 different regions for the reason that, of course, an organ that has been extracted from the dead person only has so many hours to be viable. And so therefore, the proximity to the transplant center is important. And there are other factors too, of course, like rejection, risk of rejection. The blood type has to be the same, and there's other minor factors, including CMV. Did the patient have? Is it positive or negative for CMV? Because that's a high risk if there's mismatch there for the patient to post-operatively for how he may do. The numbers go between 1 to 100, and where you fit on this list, on this waiting list, depends on the urgency for an organ. Like for instance, if you need hospitalization on high flow oxygen, then you immediately would get 20 points extra. And versus if you function well as an outpatient, then the numbers will be a little bit lower. Height and weight, oxygen requirements, and so on. All these factors play a role here. Typically what they do, they collect all this data and send them in, and it's processed by computer. It spits back, so spit back a number. The PFTs for our patient at this point, again, similar to what it was before. So the transplant score for this patient was 35. So what's that mean? But typically, at least within the Mayo system, they say if you're below 40, you might as well go home and live your life for a little while till your score gets worse. Anything below 40 is kind of waiting, and so nothing's going to come around tomorrow. So let's, again, back to our patient and see what happens over the next 2 years, which will bring us to year 10. So he continued to use oxygen, went from the original 2 liters up to 6 or 7 liters. He had some weight loss. Had some increasing weakness, muscle loss, but he was still working. And physical exam, of course, very coarse crackles. And now there was also a clubbing of the fingernails. So at this point, year 10 now, the transplant score was 46. So that was clearly now into the possible transplant when something comes around and there's no one ahead of you that had an equal match. Of course, with the pulmonary PFTs at this point, it was pretty dismal. And again, death is down here. So it looked pretty ominous. Chest X-ray looked really terrible. But I think maybe at this point you figured out that this patient was actually me, and it was. But just to present a little bit more objectively, I wanted to do it this way. So they put me on the transplant list in Rochester, and I was on it for 8 months, and there was no good match that came. And so it was decided at that point, and I'll go into that a little bit later, how that happened, but they decided maybe we should think about listing you both in Jacksonville, Florida, Mayo Jacksonville, and in Rochester. And then if there's a match coming up down there, we'll just put you on the airplane, and we have an air ambulance, just put you on that fixed wing airplane and send you down there. So here on June 5th, 2019, I got this phone call on my cell phone that it's kind of, I saw the number, it was a Florida number, and I recognized the Mayo number there. And it says, "Hi, I'm Dr. Haddad. This is Peter Smars. Yeah. This is the call," he said. "Can you make it down here in 7 hours, 6 or 7 hours?" Yeah, I think so. let me call the airplane or fixed wing program and see if they can do that. And then I hung up, and it was that short. I wonder if this was a prank call, but nobody would be that mean or cruel to play. But fortunately, fortunately, a few minutes later, maybe 10 minutes later, then the transplant coordinator from Florida called me and said, "Yeah, this was a real call." So I called their fixed wing, Mayo fixed wing, and said, "Can you fly me down?" "Yep." They said, "We can leave in 1 hour. Can you make it down?" We had about half an hour drive to the airport. So we grabbed our bags. Of course, we were told, pack your bags, be ready to go, because you don't have that much time when you get that call. You better just grab your bags and run. And so we did. Of course, we had 3 little kids. And so we had to call the neighbor over and say, "Can't you come over and maybe watch them for a few hours till Grandma can come and take over taking care of them?" And so, yeah, he was right over. And so here we are in the airplane, my wife, and it was a little bit unusual, of course, because the flight nurses here, I knew them well. I worked with them for 20, 25 years, maybe, or maybe longer, one of them especially. And so I knew them well. So we just basically had a good conversation going down there. It was a good journey. So on June 6th, very, very early in the morning, I had a double lung transplant. And they tell you very, very cryptically almost, they say, well, the lung, in my case, it says, your lungs came from a young male from Central Georgia. That's all they tell you. And so I had my operation. And so what is this? Well, it's actually my old lungs. And this state of fibrosis, they call it hepatization. And if you look at this slide now, the patient, these lungs have been in preservative for presumably hours or whatever time they take. And now it really looks like a cirrhotic liver to me. I don't know what you guys think, but that's my impression when I look at this. So here's a biopsy slide from this. And yes, it looks, even for a non-pathologist, I'd say it probably looks a little bit abnormal. But if you compare that then with what does normal lung tissue look like? It looks like this, and this was my lungs here. And they refer to this change here as honeycombing. And if you think of it here a little bit, it kind of have that sense that, yeah, there's kind of a honeycombing here. But anyway, that's what they call it. Here's a little bit higher magnification, and you can see all this fibrotic tissue deposition around the airways here, all over the place. A lot of fibrosis. A little bigger, more magnification yet. Now you can see all these chronic inflammatory cells here, and right next to the airways, the very reactive pneumocytes. Again, this indicates a very active disease. So here are the new lungs from a young male from Georgia. And post-operative chest X-ray here looks a lot better. 2.5 years later, looks pretty normal. PFTs, of course, it took a dramatic jump from down here to up to here, and then over the next couple of years progressed actually to improve, which apparently they often see. And that has to do with your breathing muscles, and that because as your lungs progress and scar down, you have very shallow breathing, and then you get a nuance. It takes a while for not only to get the muscles stronger, but also to relearn a better breathing. So let's again change gears here and look at this story from my own very personal point of view. And it's a very personal story, so it is what it is. So it is a story of immense gratitude for the gift of life. First and foremost is a gratitude to God, who is the ultimate source of life. And he showed me that without a doubt whatsoever, that he led and had a direct involvement in the planning and the care and outcome of this journey. And of course, I have an immense gratitude to the Mayo Clinic, we call it the Mayo family, believe it or not, but that's how a lot of us feel like it is a Mayo family. And so their clinical expertise and truly loving care and obvious joy at the workplace, and I'll go into that a little bit later, and what impact that made on me. I'll expand on that a little bit, but I will never forget that. Then friends and family and their role. There were people, co-workers, colleagues, people that maybe I recognize their faces on only, that would come up to me and say, I've been praying for you. Some of them sent notes, people that I hadn't heard of maybe for years would send me notes. You know, I've been praying for you and I wish you the best and so on. And like one time, going back to people whose faces I only recognized, was one guy, he was a transporter at St. Mary's. I had seen his face, of course, but you don't know the names. And he stopped by my telemedicine office one day and he said, hi, Dr. Smars, how you doing? Oh, I'm doing okay. I said, well, he said, I just wanted to let you know that me and my prayer group, we've been praying for you every week, and we will continue to do so. And other very surprising stories. Let's see if I can move this here. A lot of churches prayed for me. That's what I was told. Of course, my home church in Dodge Center, Minnesota, I knew they were praying for me probably every Sabbath. And but there are other ones. Somebody told me there was a Native American church in northern Wisconsin that had a prayer session for you. Somebody must have heard about it and brought it there. Another very, wow story was I was told by someone that there was a Catholic convention in Spain, and someone there had heard about my case, and they brought that up for a community prayer. So the outreach and the power of prayer was beyond belief, and made an incredible difference to me. But let's go back then, just even a little bit more personally here, and how God's leading in this was throughout the course of this. So back in around 2017, or about 2.5 years before the transplant, when my PFT curves were really hitting that bottom, getting close to that bottom line, one of my friends, I was talking to him, and he said, well, maybe we should have an anointment service. And I'd heard about it, people doing that. And I said, yeah, that's a good idea. So he invited another good friend of ours, Michael Ryan. I don't know if some of you might know him. It's a general conference. He was, I think he's retired now, but so he came out a few months later, and we had an anointment service in our home. It was profoundly touching and meaningful. And Mike explained to us that he had seen 3 different outcomes to these anointment services. Sometimes it would be miraculous change and the patient would get better almost immediately. That would happen sometimes, but maybe not all that often. Sometimes, on the other hand, nothing seemed to happen. But most commonly, they would see, okay, so the patient's course, just like mine, had kind of started to go down, down, down. They had this service, and then it started to go gradually better and better and better over time. And that was most common, most likely to happen. In my case, of course, let's see here, I've had a little difficulty here. Anyway, so in my case, nothing happened immediately. So I was, okay, well, we'll wait and see what happens here. So again, remember, anointment service was late Friday night. On Monday morning, I had an appointment with my pulmonologist, and he had never talked about, except for he had mentioned one time that I would die of something different. I would not die from this. This was maybe 2 or 3 years before this point, or maybe 4 years. So he came in as kind of a quiet guy, and came in and looked at the computer. Then he looks at me and says, have you ever thought about a lung transplant? And I said, yes, as a matter of fact, I've thought a lot about it, because I knew where we're heading, even though he had told me differently. I had very little doubt about that. So at this point, then that was the answer to the anointment service. I knew that God answered our service in this way, and that gave me such reassurance. So from then on, I had absolutely no worries, no fear. I was, it's going to happen. It's going to happen at the right time, and it will be a good one, unless, of course, I interfered or did something stupid. And that's typically what happens. God will lead us, but then we say, I'll take it from here, and then things go bad. But I was praying that I would not do that, try not to do that. So again, that was very reassuring. And the Bible tells us that's how it works. He says in Isaiah 41:13, it says, for I am the Lord your God, who takes hold of your right hand and says to you, do not fear, I will help you. It's right there. And so that's exactly what I felt and experienced. And in another verse that I kind of live with every day was, yea, though I walk through the valley of the shadow of death, I will fear no evil, for you are with me, your rod and your staff, they comfort me. And if there's ever a journey when you know that if you continue this way, that is the valley of the shadow of death. So, but again, I knew I had no fear, I had no worries, because his rod and his staff, they comforted me. From the time of the anointment service, also, I had many other reminders. There are too many to really go into by detail here, but just to kind of explore a few of those here, the Bible talks about God's still small voice in 1 Kings 19:11-13. And I believe that many of you know what this is. Some of you may not know what that is, but if you have, I don't know if there's a psychiatrist in here or not, but if you are, believe me, we're not hearing voices. This is instead you typically get a very strong impression, a thought, you can't shake it, and then something comes up to confirm that that's really was his voice. Now, of course, it has to be in line with the Bible. It's not going to be something outside or contrary to what the Bible teaches. But so it's important to keep that in mind. But obviously, I was not alone by far in hearing or in listening to God's still small voice. For instance, one day while I was sitting in my office, and working. And I get this email from my secretary who says, there's a Sister Tierney from Sissy Heights, which is a nunnery up the hill, who wants to see you this afternoon. Well, my immediate reaction was, uh-oh, what did I do now? Because you see, St. Mary's Hospital, which is a big hospital at Mayo, they're overseen by what's called an ethics committee. And they, of course, they say, okay, you can do these procedures. You can't do those kind of procedures, like typical things like abortions are not allowed at St. Mary's Hospital and similar things. But there are also others, if there are questions of ethical behavior that perhaps needs to be reviewed, they would do something. I thought, well, maybe I did something wrong here. I couldn't think of it, but she was kind of come and see me. So I said, sure, of course, come and see me. So she comes into the office and sits down, and fortunately I was not in trouble. She said, oh, I just wanted to stop by and thank you for the care you gave me when I was here in the emergency room 8 or 9 months ago. And I kind of vaguely remembered I'd seen one of the nuns from up there, but I hadn't really put it together yet. So, and she said, I just wanted to come and say thank you for that. And in fact, she says, I've been struggling with it for all these months. How should I communicate my thank you? And it was like almost no. So should I write a letter? No. Should I write a card? Maybe not. Should I go see him? Yeah, maybe. But there's always something that came up. But she said that morning, she said, well, she was going to come down and see me. And so, and of course I'm sitting there with oxygen on. And so she stopped herself and she says, is there something wrong? Well, yeah, I have this lung disease. I'll be dead in 2 years if I don't have a lung transplant. She got off the chair and she says, oh, I knew it. I used to have this strong feeling this morning. Today is the day you have to go see him. And so she came and she says, I have a prayer list. It's about 2 hours long. I wake up in the morning, take my dog, go for a walk, and then I go on my knees and I pray for 2 hours, and you will be on that list every day from now on. And so every month or two, I would get a letter, an email from her saying, how are things going? I'm still praying for you. And another story that kind of also confirms the fact that other people here, it's sometimes other people that are unexpectedly that you wouldn't think of it. So one day I was sitting in my telemedicine office actually, and it came on me was that, why don't you, because we had this policy at Mayo that if you want to be double listed, both at Mayo Rochester or Jacksonville or you'd have to choose one. You could be officially okayed on either site, but you would only be eligible to get the transplant in the city where you're at. You could not travel. That wasn't, and I don't know how it is here in Loma Linda, but if we try to make some major changes at Mayo, policy, procedures, and so on, it takes months, typically committee meetings and decision making and collaboration. In this case, it would be collaboration between both Jacksonville and Rochester. And so I thought, well, at least I thought I'll try to contact the head of the transplant team. I think you know him, John Scott, and see if he could maybe at least explore this. So the next day, I'm again in the telemedicine office, and in walks my department chair. Didn't say much, but he says, I just came from a meeting with Dr. Fruja. Dr. Fruja is the CEO or the president of Mayo. He's the top guy. And after the meeting, he came over to me and he said, has Peter thought about being double listed and we could fly him down? Well, I don't know, he said. So he came directly down to me and he posted this question. Have you thought about it? Yeah, I've thought a lot about it. I said, especially in the last 24 hours. And so, oh, okay. So then after he left, I wrote an email to Dr. Scott again and asked if I could set up an appointment. And I got almost an immediate answer back. He said, no. He says, just call me as quick as you can. So I did. And I mean, I got halfway through my little spiel there. And he said, yeah, let's do that. I'm going to go down to Jacksonville next week and I'll talk to them and maybe we can make something happen very quickly. Well, I didn't have to wait that long. Next morning when I got up at 7, then here's an email already. Can't remember what time, but it was an early email that he had written. Oh, I said, don't worry about it. It's already taken care of. I've talked to them already, and we're gonna make it happen. That doesn't, to me at least, it doesn't happen very often at Mayo. So then of course he said you have to be approved by their team, by the transplant team, but we can do that from here. And they're going to have their official meeting next Wednesday. So probably a few people to talk to, and then they'll discuss this. And then of course next Wednesday, I got the call and said, yeah, you're on the team. Oh, you're on the list down here. And so lots of processes and changes here, like the Mayo fixed wing had to be ready to fly me down there, and that's not that easy. They had to create a different call schedule, and et cetera, and back up if they weren't there, and so on. So lots happened there, and it was amazing. So that's how I ended up with my transplant. So here I am, probably post-op, woke up. I don't have any recall of this at all. Obviously, I was probably on sedation and Versed that diminishes your memory and so on at the time. But apparently they did an echo, an ultrasound, I assume looking for bleeding or whatever. But they also said, oh, your cardiac ejection fraction looks really good, 65%. And of course, being echo trained, that's what I focused on. In fact, it's possible it hadn't even dawned on me that I had my transplant yet. So anyway, so that's that little story. But really, once they stopped the sedation, I woke up and they extubated me. And I remember from that point, what struck me so intensely was everybody was so happy. Nurses talking to the doctors and to everybody. It was like a happy team, and it was a really joyful atmosphere. And even at 7 o'clock in the morning, when there were a shift change, they stop in the chat and ask, very, very personal. And even that, when they stood out there and you could sense this presence of joy and happiness, what impact that made on my belief in them and my recovery and happiness of being in there, it was incredible. And obviously, I've been in the ER for more than 30 years, and we have a pretty happy team most of the time, and a lot of camaraderie between everybody. But I'd never even thought how that would impact on our patients. That if we were like that, we were happy, then that would translate into their strength and recovery from what they had. And that was all brand new to me. So what lessons did I learn as a provider, really, was the positive effect of this joyful atmosphere. And that's something we can do something about as we work with our team. We can bring that in, emphasize that, stimulate that the best we can, and realize, if not just for ourselves alone, but really for our patients, it really makes a difference. But more than that, of course, if we as providers and hopefully as the patients can understand and get to learn the divine intervention and depending on God and his absolutely personal intervention, holding our hands through all of this and guiding the outcome, if we let him guide us, it makes an immense difference in that care. Of course, it also, if we have that faith, it makes an incredible change in our own personal lives as we go home and we live our normal lives. So that's my story as a patient. Well, then you come to here. So obviously there are many patients with same disease that I have that don't get this chance. There are not enough organs out there to give to all the people who need them. So why was I so lucky to give them? I do believe that we all have a calling. Every one of us have a calling. And being retired or close to retirement, the calling doesn't stop there. It may change what you're called to do, but you still have a calling, and you have to listen for that. You have to sense it, and you should, if you really want to have a good life, follow it. It's an incredibly blessed thing to follow that calling. Of course, I could say, well, my family probably needs me for a few more years. Here are my 3 little children, and they obviously need a father, I hope and I think, for quite a few more years to go. They need a dad for sure. And that, besides that, in my work at Mayo, what am I called to do? Well, here, we backtrack here to probably around 2003 to 5. Larry Thomas here on the right, who I think many of you know, he and I went to Ethiopia several times to try to help out people and do what we could and assess, besides being an interesting travel journey. And so on one of them, actually, Larry actually knew John Scott here. He's a famous theologian, and he introduced me to him. And it was on that journey, actually, is when we decided to let's just go ahead and form a fundraising organization. Of course, Larry, he was the driver in this, and he ended up doing 99+% of all the work. But I was the secretary, and then we had another member in Denmark, Henrik Jorgensen. So we had an official board. We're 501c. And as you know, a little bit over a year ago, Larry suddenly died. And what do we do now? He done 99% of the work, and we don't want to stop this. It's a great thing. A lot of people are very, their life changing, the things we can do with the funds that people have donated to us. So we started this organization, Tropical Health Alliance Foundation, and the aim was to provide, it would be a tool for healthier lives in Ethiopia. So what we focused on is 5 different main categories. Here, one of our big ones, to provide cataract operations to patients that were totally blind from the cataracts. This is actually quite common in Africa, and these people are anywhere from actually teenagers on up to the 30s and 40s and 50s and so on. And since they're totally blind, they need a child to lead them around. They don't have seeing eye dogs. They have a child that has to be with this individual for 24/7. So they take this kid out of school, and he leads grandpa around, and he or she can't work, of course. And so if we can even provide one cataract operation so they can see again, the grown-up, the adult can go back to work, and the child go back to school. So really fundamentally affects we have done 24,000 operations so far in Ethiopia, and all of them have been successful. And so, but really the impact here out of those 24, not only for the 24,000 patients that got the operation, also 24,000 children can now go back to school and live a normal life. We also have a group out there that works on patients with pseudoconiosis. Maybe some of you don't know what that is. It's really a lymph obstruction problem where that they get from walking barefoot on certain sand, volcanic sand, where these crystals come into their lymphatics and scars them up. What you see will be very similar to elephantiasis, but obviously the cause of it is different. And so there's things we can do not only to treat, but the biggest thing is to prevent it by handing out shoes and so on. So we do that. Disabled children, these kids would otherwise, if they survive, would end up on the street, basically begging for whatever. And so we can help teams. They're already out there that didn't have the funds to do so. Now we can enable them to help these kids out. Water projects. There's a lot of unsafe water. We can set up certain water systems where they can get fresh water. A big program is various programs actually under this category, women and children. And I don't know how we're doing on time here, but both from gynecologic surgeries that we pay for to sanitary products, to education, children going to school, orphans to orphanages, and it's a pretty wide category here. Also, we've paid for a number of flour mills. Typically, these women will, one day a week, they would take two stones, they would put their teff seeds in there, and they would grind them to get the flour. So it would take 8 hours to provide flour to last for 1 week. And now we send these mills out. They can serve 6,000 to 8,000 people, and they can get their flour for a month done in about 20 minutes. So it's very impactful. Of course, you probably heard of all the chaos with the civil war in Ethiopia. Fortunately, it's much more contained, but it's still not over yet. And the people, lots of people around there, millions actually, who were displaced. They lost everything, and they don't have anything to sleep in. Some of them don't have a blanket, and they don't have food. So we've been able to send out so far about close to 100 tons of flour. That's 220,000 pounds of flour, so they can at least live and not starve.